Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arua, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very handy in your line of duty. I now welcome you all to part 216 of our Pharmacotherapy MCQ series, which majors in infectious diseases. And the first question reads, TMC, is a patient who recently started taking medication for active pulmonary tuberculosis. TMC has been taking his medications regularly and his pulmonary symptoms have been improving. Unfortunately, TMC has begun to notice visual changes, including decreased visual acuity and disturbance in his perception of color. So my question to you is, which of his medications is the most likely culprit? Is it A, clarithromycin, or B, ethambutol, or C, isoniazid, or D, pyrazinamide, or is it E, rifampin? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is B, ethambutol. I will justify why. The most important complication of ethambutol therapy is optic neuritis, which can manifest as decreased visual acuity, restriction of visual fields and disturbance of color vision. Other important side effects of antituberculous medications include hepatotoxicity, peripheral neuropathy, hypersensitivity reactions, bone marrow suppression, and orange discoloration of bodily fluids. Please advance to the next question. And the next question reads, CTS, a 42-year-old male cigarette smoker presents with several months of fever, night sweats, weight loss, cough and hemoptysis. CTS's chest radiograph showed bilateral pulmonary infiltrates with left upper lobe cavitary disease. Sputum samples were obtained for acid-fast stain and the stain was positive. An interferon gamma release assay was obtained, and was also positive. PCR on the sputum sample was negative for detection of Mycobacterium tuberculosis. So my question to you is, what is the most likely cause of his symptoms? Is it A, Mycobacterium bovis, B, Mycobacterium gordonii, or C, Mycobacterium kansasi, or D, Mycobacterium marinum? Or is it E, Mycobacterium ulcerans? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is C, Mycobacterium kansasi. I will explain why. Sensitivity of PCR detection of Mycobacterium tuberculosis is high on smear-positive samples. Positive interferon gamma release assays have been reported in association with Mycobacterium kansasi infection. Mycobacterium kansasi infection can present with insidious pulmonary and constitutional symptoms and is frequently associated with hemoptysis and cavitary lung disease. Disseminated infection may also be seen in HIV-positive patients. Please proceed to the next question. And the next question reads, DMT, a 72-year-old woman with chronic obstructive pulmonary disease was referred for evaluation by her pulmonologist because of refractory pneumonia. DMT has received multiple courses of antibiotics over the past few months because of non-productive cough and chest imaging that demonstrated multifocal pulmonary nodules and some cavitary lesions. DMT also has had prominent fatigue, night sweats and weight loss. An interferon gamma release assay was performed and was negative. DMT underwent a bronchoscopy and the culture results grew a causative pathogen. DMT was started on antimicrobial therapy. So my question to you is, what is the most likely regimen DMT was started on? Is it A. azithromycin, ethambutol, and cepoxetine, or B. clarithromycin, ethambutol, and rifampin, or C. rifampin, isoniazid, and ethambutol, or D. rifampin, isoniazid, pyrazinamide, and ethambutol, or is it E. rifampin, isoniazid, and streptomycin? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is B. clarithromycin, ethambutol, and rifampin. I will clarify why. This patient has infection with Mycobacterium avium. Her CT shows bronchiectasis with some cavitary lung lesions and pulmonary nodules. Recommended therapy for Mycobacterium avium complex includes a macrolide with rifampin and ethambutol. Aminoglycosides may be added in cases of more severe or relapsed disease. Please proceed to the next question. And the next question reads, OME, a 23-year-old man with HIV was admitted to the hospital with septic shock. His CD4 count is 25 per microliter and he is not on antiretroviral therapy. On examination, OME had diffuse rhonchi and he was noted to have multiple papular skin lesions. His chest radiograph showed bilateral pulmonary infiltrates. OME was started on broad-spectrum antibiotic therapy. 4 days into his hospitalization, his blood cultures grow mold. OME also had a skin biopsy done and Gamori methenamine stain of the tissue shows 2-4 micrometers yeast forms. In addition to antibacterial therapy, what other antimicrobials should be instituted in OME's case? Should it be A. 5-flucytosine, or B. amphotericin B or C. fluconazole, or D. micafungin, or should it be E. trimethoprim sulfamethoxazole? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is B. amphotericin B. I will justify why. This patient has disseminated histoplasmosis, which can cause a sepsis syndrome in HIV-positive patients. He should receive amphotericin. Caution should also be taken to look for additional opportunistic processes, as with his degree of immunocompromise he is at risk of having more than one disease process. Please advance to the next question. Pause the video and carefully scrutinize the photo below before answering the next question. The yeast seen in this lung biopsy specimen is most likely what organism? Is it A. Blastomyces dermatidis, or B. Coccidioides immitis, or C. Cryptococcus neoformans, or D. Histoplasma capsulatum, or is it E. Paracoccidioides brasiliensis? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is B. Coccidioides immitis. I will clarify why. This photograph shows several coccidioides spherules with containing endospores. Please proceed to the next question. Pause the video and carefully scrutinize this representation of a patient's CT scan before answering the next question. TLC, a 24-year-old, HIV-negative, man is referred for evaluation of chronic pneumonia. TLC has had multiple courses of antibacterial therapy and still has a significant left lower lobe consolidation as seen on his chest radiograph. On chest CT, the area of consolidation was thought to be a mass-like lesion and he was referred for biopsy. In the interim, TLC also developed multiple verrucous skin plaques. TLC undergoes a bronchoscopy with transbronchial biopsy and the pathology shows granulomas and broad-based budding yeast forms as pictured in the photo above. So my question to you is, what is the most likely diagnosis in TLC's case? Is it A. aspergillosis, or B. blastomycosis, or C. coccidioidomycosis, or D. cryptococcosis, or is it E. histoplasmosis? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is B. blastomycosis. I will clarify why. Blastomycosis appears as broad-based budding yeast in tissue. Pulmonary blastomycosis can present as non-resolving pneumonia, cavitary pneumonia or a mass-like lesion that can be confused with multiple other entities, including tuberculosis and lung cancer. Cutaneous lesions are the most common extrapulmonary manifestation of blastomycosis and typically appear as well-demarcated plaques or ulceronodular lesions. Please proceed to the next question. Pause the video and carefully scrutinize the picture below before answering the next question. And my question to you reads, which of the organisms listed below is the yeast seen in this lymph node aspirate most likely to be? Is it A. Blastomyces dermatidis, or B. Coccidioides immitis, or C. Cryptococcus neoformans, or D. Histoplasma capsulatum, or is it E. Paracoccidioides brasiliensis? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is E. Paracoccidioides brasiliensis. I will explain why. This photograph shows the typical captain's wheel appearance of Paracoccidioides. Please proceed to the next question. Pause the video and carefully scrutinize the picture below before answering the next question. ACG, a patient with recent left upper molar tooth abscess and dental extraction was admitted with 2 weeks of progressive fever, headache and left-sided facial swelling. On examination, ACG had significant left facial cellulitis, with left eye proptosis, ptosis and cranial nerve 6 palsy. So my question to you is, what is the most likely explanation for ACG's symptoms? Is it A. cavernous sinus thrombosis, or B. Lemierre's syndrome, or C. Ludwig's angina, or D. Ramsay-Hunt syndrome? Or is it E. sagittal sinus thrombosis? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is A. Cavernous sinus thrombosis. I will explain why. Cavernous sinus thrombosis can complicate mid-face infections, most commonly sinus infections, or primary skin and soft tissue infections, but can complicate odontogenic infections. Symptoms may include fever, headache, encephalopathy, facial and periorbital swelling, and deficits related to cranial nerve involvement of cranial nerves 3, 4, 5 and 6. Please progress to the next question. Pause the video and carefully scrutinize the picture in this slide before answering the next question. KLM, a 47-year-old man is sent from otolaryngology clinic for evaluation of a chronic left mandibular wound. KLM has poor dentition and has had multiple tooth extractions. KLM has, for the last 2 months, had swelling and intermittently draining sinus tracts over the angle of his mandible. Superficial wound cultures have not grown any pathogens. Imaging does not show any signs of mandibular osteomyelitis. So my question to you reads, which of the antimicrobial classes listed below should be included in KLM's first-line antimicrobial therapy? Should it be A. aminoglycosides, or B. glycopeptides, or C. nitroimidazoles, or D. oxazolidinins, or should it be E. beta-lactams? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is E. beta-lactams. I will justify why. Cervicofacial actinomycosis is most often treated with penicillins. A variety of other agents have been used with success, including cephalosporins, carbapenems, clindamycin, tetracyclines, erythromycin and chloramphenicol. Please proceed to the next question. And the next question reads, which of these is not a recommended treatment regimen for Helicobacter pylori infection? Is it A. omeprazole, clarithromycin, and metronidazole? Or B. omeprazole, clarithromycin, and amoxicillin? Or C. omeprazole, bismuth subcitrate, tetracycline, and metronidazole? Or D. omeprazole, levofloxacin, and amoxicillin? Or is it E. omeprazole, clarithromycin, and tetracycline? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is E. omeprazole, clarithromycin, and tetracycline. I will explain why. Treatment for infection with Helicobacter pylori requires combination therapy with multiple antibiotics. The first 4 regimens listed comprise the first and second line recommended regimens for treatment of Helicobacter pylori infection. Clarithromycin resistance is uncommon, but increasingly prevalent, so if a patient fails regimens A or B, treatment with an alternative regimen as listed in choices C or D is recommended. Please proceed to the next question. And the next question reads, 3 people are brought to the emergency department by ambulance from a conference at a hotel banquet hall. All had been taken ill within a short time of eating at a buffet that included fresh tuna. The patients all complained of headache, dizziness and flushing. They were all mildly tachycardic, but none was febrile or hypotensive. So my question to you is, what is the most likely cause of their symptoms? Is it A. bacterial infection, or B. histamine ingestion, or C. parasitic infection, or D. toxin ingestion? Or is it E. viral infection? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is B. histamine ingestion. I will justify why. These patients have scombroid poisoning, which is caused by excess histamine production from bacterial overgrowth in poorly cleaned or stored fish. It is most commonly seen with oily fish, including tuna and mackerel. Symptoms include flushing, vomiting, diarrhea, dizziness and palpitations, and patients typically become symptomatic within an hour of ingesting the contaminated seafood. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arua, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 217.